Welcome everyone to the Cancer Conversation. This is a space where we talk honestly about cancer, but also the very real reasons for hope. I am your host Ekta, and today's episode is brought to you by Delarc Pharmaceuticals. If you or someone you love has faced breast cancer, you know that the word treatment can feel overwhelming. But here is the good news: treatment today is not what it used to be. We've moved beyond a one size fits all approach into a new era of precision, personalization, and possibility. And guiding us through this journey is someone very special. Dr. Shailesh Bondarde, one of Nasik's leading medical oncologists, who has dedicated more than 25 years to helping breast cancer patients and families find hope. Thank you so much, Dr. Shailesh, for being a part of this very interesting and very needed conversation. So, because we're talking about advancements in breast cancer, let's take a look back into time. Let's consider a woman who was diagnosed with breast cancer about 20 years back. What did her journey exactly look like? And if we compare it with somebody who's recently or newly diagnosed with cancer, what does she experience? How does the difference look like?
So at the outset, Ekta, I would like to thank you, for engaging with this in this conversation of such an important topic of breast cancers. And the question which you have asked, I have seen the treatment changing in last 2 decades because I have been practicing for last 25 years. So I have seen the changes what has happened in the management of breast cancers. 20 years back, all females with breast cancers used to undergo mastectomies. That's removal of the breast. That's no more required. All the patients used to take chemotherapy. Not all patients requires chemotherapy today. There are many newer advances in chemotherapy, less toxic chemotherapy, more precise treatment available, better radiotherapy equipments available for local radiation as compared to the cobalt which we used to use 20 years back. Now we have precise linear accelerators. So treatment has become more easier, more precise, and with better outcomes. People are thinking of conserving as much of breast as possible for patients with early breast cancers. Even in locally advanced cancers, you can downstage and still give an option of breast conservation for these patients with even in locally advanced breast cancers. So things have changed a lot. It's not only the quantity of life which we have improved, but also the quality of life of these patients undergoing treatment.
So, can we just say that, it's not just one type of cancer, one type of breast cancer, because there are so many treatments, or how would we describe it if we have to?
So, in short, I can tell that it's not one fit for all.
Okay.
So every patient is a different patient. Even if the patient is of the same stage, same size tumor, the treatment can differ. So we have a breast cancer patient, a young breast cancer patient, an elderly patient, and young patient with a triple negative breast cancer, elderly patient with an estrogen receptor positive early breast cancers. So the patient who is young, triple negative, will require a very aggressive treatment. Elderly lady with an estrogen receptor positive tumor can just be treated with hormone therapy after surgery. So every patient is a different patient. It's like you said, what is the difference 20 years back and today? This is the difference. 20 years back, all used to be treated in the same way. Today, we have different therapies, different lines of treatment, more conservative surgeries, and not one fit for all. So every patient is a different patient.
Right. Thank you so much for that. Now, when we're talking about the kind of therapies that they'd be taking, let's consider immunotherapy for the time being. Earlier, people used to think that many people, in fact, till date, think that the body's immune system is something that fights cold, cough, or basic illnesses. Is there any way that we can actually, through immunotherapy, we can train our body's immune system to fight something as big as cancer?
So that's an excellent thing. What has happened in last decade or so, where a patient's own immune system is being used to fight diseases, even like as big disease as a cancer.
Right.
So immunotherapy, if you if you see the immune system and the immunology, how it is being used in the management of breast cancers, or for that matter many other cancers as well, there are many things which happen. One of the most important thing what happens is the cancer cell gets a protein called as PDL1. Okay. And this is the protein on the cell which inhibits the action of T lymphocytes. That's the cell which kills the cancer cell. And because this protein occurs and there is an inhibition of this activity, the tumor cell grows. That's how is the basic mechanism of growth of a tumor. Okay. Now we have drugs called as immune checkpoint inhibitors. Now this drug inhibits this particular activity, and it sensitizes the T cells against the cancer cells, so that our own T cells, which are actually known to kill these cells, get activated. And you get the tumor cells killed by this T cells. This is one of the mechanism. There are many other things. For example, there is a lot of talk about the CAR T cells. Now, this CAR T cell basically is the mechanism by which the T cells are removed from the body. They are engineered outside the body for the antigen which is present on the cancer. They are grown and multiplied outside the body and then infused into the body. So that's how the CAR T cells are generated against the cancers. There is another mechanism by producing antibodies. We all know about the antigen antibody and the complex which occurs in immunology. These antibodies are artificially made against the antigen which is present on the cancer. And we have many drugs in breast cancers like trastuzumab, pertuzumab. These are the antibodies which are available. And these are artificially made antibodies which are used against the cancer antigens. And the latest, we have these antibodies tagged to the chemotherapy, which we call as ADCs, that's antibody drug conjugates. And the newer drugs like trastuzumab deruxtecan are the drugs, is the drug which is in lot of talk right now. Mm-hmm. And it's been hugely successful in management of metastatic and advanced breast cancers. So it's also been used and is in research for early breast cancers, and likely to be the big thing which is happening is likely to happen in the near future. So this is the different mechanism by which we are engaging the immunology and the immune system, yeah, for treating breast cancers.
Okay. So this, I feel, maybe for our listeners, an easy way could be maybe imagine cancer cells wearing an invisibility cloak, and the immune system cannot see them. Let's consider it to be like this. And the immunotherapy actually strips off that cloak, and it allows the body's own defense cells to recognize and then attack the cancer cells.
That's absolutely the gist of all what I said.
Yeah. So, who are the patients that can benefit the most from this kind of unmasking therapy? Because you said that there are going to be different types of cancers.
Absolutely.
Right?
Absolutely.
So, who would benefit the most from immunotherapy?
So, patients which are triple negative are the ones in the um, non metastatic setting, in the sense the disease is localized, has not spread to other organs. Triple negative patients can be treated, and in fact should be treated with immunotherapy. And the drug is pembrolizumab. And also for the patients where the disease is spread. So for those patients where the disease is spread, we do the PDL1 marker on the tumor. And if it is more than 10%, those are the patients where immunotherapy works in patients where the disease has spread. Looking at the other immunologically drugs which are available, there are many trials ongoing. So we might have further future options as well. But as of now, that's what we use when we use immunology in breast cancers.
All right. So it is actually very inspiring to see that a patient's own immune system can actually become their strongest
Absolutely.
weapon, right?
Absolutely.
Like it's your own body fighting against something that was already present in your body. So
Correct.
it's very inspiring. From training the body's army, let's move to another major advancement, that is targeted therapy. People often compare chemotherapy to carpet bombing. Targeted therapy, on the other hand, is like a guided missile. Is that a fair enough way to describe it?
So let me explain. So chemotherapy is basically a treatment which acts directly on the cells and kills it.
Right.
Immunotherapy is the one which boosts our immune system, and our immune system kills the cells.
Right.
Targeted therapy is a antibody which is against the antigen which is present on the cell. So for before giving a targeted therapy, we should know what is the target which is present on a cancer cell. So the first thing what we do is test the breast cancer cells for the targets. The first target which we always, I mean, which everybody talks about is basically an HER2 positivity on the cell. But I feel the first target which was found to be on the tumor cell was way back, almost 45 to 50 years back, was an estrogen receptor on the cell where hormone therapy can act. So that's, I think, is the first target. But everybody talks about the HER2 antigen, which is on the cell, against which we have antibodies like trastuzumab and pertuzumab, and now we have ADCs like trastuzumab deruxtecan. So for estrogen receptor positivity, we have hormone therapies like tamoxifen, we have aromatase inhibitors. Recently, we have CDK4/6 inhibitors. Then we have PIK3 inhibitors, and there are a lot many drugs which are in pipeline for an hormone receptive breast cancers, may it be an early stage or in advanced stage. And there used to be a time when I started my practice 20 years back, all patients with metastasis, whether they are estrogen receptor positive or negative, used to get chemotherapy. Today, we can manage these patients with tablets, hormone therapies, and this hormone therapy can go on for years together. They can have survival without chemotherapy for 3 years, 4 years, and then later they will get chemotherapy. So we have a good quality of life taking just tablets for 3, 4 years, even in an advanced stage. The survival for advanced breast cancers used to be 1 year or 2 years. Now I have patients surviving for 14 years, 15 years with a metastatic disease. So things have changed a lot. Another target we talk about is trastuzumab, pertuzumab, and the recent data shows that even at 7 and 8 years, around 33 to 35% of the patients are surviving at the end of 7 years with the targeted therapies. Disease well controlled, good quality of life, taking an infusion once in 3 weeks, coming for half an hour to the hospital. That's how the targeted therapy works. So if you have a target on tumor, you are likely to have a better survival as compared to no target on the cells. That's what we call triple negative. Those are the bad cancers. Okay. If you have a target, you have many options which are available.
Right, right. So, HER2 is like an accelerator pedal that has been stuck down, making the cancer grow faster. And targeted therapy acts like a smart key that locks that pedal, slowing the growth. How has this changed life expectancy and quality of life for women with HER2 positive breast cancers?
You said is right. HER2 positivity, when we didn't have the drug for this particular antigen, the survival used to be around 35%, and now we are talking about 85-90% survival with these patients who receive this particular treatment. And
it was also quick, as in the growth of cancer cells was also quick in case of HER2.
Correct. That was the reason why they had bad prognosis.
Right. Okay. So, well, this is, I think it's not just for living longer, but it's also for living better. And that's the reason all these therapies exist. And now, perhaps the most futuristic concept that I have also heard of is personalized care, right? We also spoke about the different types of breast cancer. So, personalized care, I think, is very important. So, if immunotherapy gives immune system new glasses and targeted therapy is like the guided missile. So, can we call personalized therapy as the master plan that can, decide which tool to use when? Because you just said that different types of cancers will need different types of tools. So, is personalized therapy a combination of these two, or does it also involve something else?
So personalized treatment is what I said, that one size doesn't fit all. So every patient is a different patient. We have different markers on the tumor. We have different treatment for different stages. So it's like a jigsaw puzzle, and you need to fit in the right boxes at the right place.
Right.
And if we are able to do that, I think we will be able to cure many more patients, and if not cure, at least give them a good long quality of life.
Yeah. So I think it's more like running a fingerprint analysis on cancer and trying to understand which, as you said, that which shoe will fit whom. So that is something that you have to do, and I'm sure it must be.
Absolutely right. I mean, when you said about the fingerprints, it suddenly struck me, that there is also something called as a hereditary breast cancers.
Yeah.
So you have around 7 to 8% of the patients which can have this gene called as BRCA, and it is important to know if the patient is having this particular gene. Why it is important is we have a drug for this, which are called as PARP inhibitors, and it is also important to not only screen for breast cancers, but this particular gene has propensity for ovarian cancers, in male prostate cancers, pancreatic cancers. So we need to keep a watch on other cancers as well if the patient is BRCA positivity, not only in the patient but in the family members also, because this is an autosomal dominant. So there is a high chance of transmission in the relatives also.
Right.
So that's another, we can call it as a target, but it's something which is present right from the birth. It's a germline mutation which is present. So if this particular test is positive, we have another set of drugs called as PARP inhibitors, which can be used in an early breast cancer also, and in a metastatic and advanced breast cancer. So that's another armamentarium of drugs which we have in this particular subset of patients, if they are found to be BRCA positive. And like, I have a journey of 25 years of oncology practice. So I have many patients whose mother I have treated, and I am now treating the daughter as well. So, and also I have a family of around 15 patients in a family. There are around 8 patients which are positive for cancers, and the rest are BRCA positive. So this is something which needs to be kept in mind, and what is important is a proactive screening for these patients. So many are afraid that if I am BRCA positive, what is to be done, so it's very, very important to have a good counseling with because there's one patient and the others are not patients. They don't have any symptoms, so they are afraid of coming forward for testing. So we require a good counseling, a repeated sessions of counseling before they come forward for testing. So this is something which is difficult to convince, but it's our duty. I feel it's our duty to tell them what's likely to be there in the future, and how to prevent it, or how to catch them early. Even if we cannot prevent it, let's catch them early.
Yeah, at least we can start doing something about it. So just like you said that, there is a fear, and there's also an anxiety. So most of the families and patients, the families of the patients or the friends also, they actually still wonder that will I get access to these treatments that we're talking about over here. Again, they also have this one particular question: are they safe? Because there are a lot of myths floating in the market. And another one, that will I be able to afford them? So, when someone says this to you, when you were saying that you would have to counsel a couple of patients here and there, if you hear someone saying all of this, what would you tell them?
So the most important thing in cancer management is catch them early.
Yeah.
If you are able to catch someone early with the cancer, you are not only going to cure them, they will require minimum treatment, and the cost of the treatment is something which almost everybody can bear it.
Okay.
So what is important is catch them early. Second, I think I must appreciate the government schemes which are available.
Yeah.
It's I always used to feel that, if I'm a doctor, it's my duty that every patient who comes to me must get treatment. And today, if I am able to catch them early, I'll be able to cure them, and I'll be able to do them for free for the patient.
Yeah.
And thanks to government for providing these facilities and schemes for treating these patients. Now the problem comes when the disease is advanced. So in an advanced disease, the problem is the cost is high, cost of treatment is high, and you cannot cure them in a metastatic setting. You might be able to prolong their life for years, however, you may not be able to cure them. So the treatment is long, the treatment is costly, and it is not curable. So you are able to control them for years, but it's not curable. So the idea and advice is proactive screening and catching them early. That's the key in the management of cancers. Whenever you have advanced cancers, you require treatment which is latest, but the latest treatment is always costly.
It is.
If you look at any Western guidelines for the management of advanced cancers, the first line is, if possible, enroll them in a clinical trial. However, everywhere in our country, at least, there is a myth that the clinical trial means an experiment. It is not. It is a very well regulated phenomenon in our country and in most of the countries for that fact. It is regulated. We have regulations, we have laws, and we have Ministry of Health looking after all these research projects. So advice is, whenever possible, and if there is a clinical research which is ongoing for these patients, they should get enrolled. You know, that's where you are likely to get the best option which is available. And again, in most of the government schemes also, even in advanced breast cancers, there are treatments available. You may not get antibody drug conjugate, you may not get immunotherapy, but at least targeted therapies are there. We have CDK4/6 inhibitors for breast cancer, advanced breast cancer. So there are a lot of things which are available. I think it's good that breast cancers are taken care of by most of the physicians and surgeons. We have a standard line of management for most of the breast cancers, and we are able to see the results as well. So proactive screening is something which I will always advise these patients.
Also, when you said all of this, they see most of these things are for advanced patients, right? There's one more myth that stays. Are these treatments safe? Because if someone comes to you at a very primary stage, they're still scared. They have this thing in their mind. So, what about them if they still feel scared about it? It's not safe, is what people think.
So one of the commonest problem what the patient faces is something called as hair loss. I mean, most of the patients, female patients, will get hair loss. We have treatments. We have a scalp cooling device where the amount of hair loss can be reduced. Also, there are a few drugs which may not cause hair loss, but the importance is whether those drugs are useful for that particular patient. Like I said, each patient is different. So it can happen that drug may not be useful for that particular patient. And in an early stage, one can avoid chemotherapy altogether. Like you have a estrogen receptor positive patient, tumor of say 1 centimeter. So you can do further tests like oncotype DX, you can do mamma print and so on the tumor. And if you get a good score, you can avoid chemotherapy altogether. So it's just a hormone therapy, 1 tablet a day for 5 years, and then you are done with it. So again, the thing is, if you are able to catch them early, you might be able to avoid most of the treatments which are only surgery as of today. So that's it. I mean, you can and the drugs which are useful for the treatment of breast cancers are safe. What is important is if we are able to now manage most of the toxicities, because we know the toxicities what can happen with these patients. For example, if you're using anthracycline, they can be cardiotoxic. uh, Chemotherapy can reduce the counts. The patient can end up with fever. So now we have good supportive care, growth factors, where we will not allow the counts to go down. Give them proactively before the counts go down.
Right.
Then another important thing which used to happen was a lot of vomiting and nausea. We have so much of a good drugs which are available to prevent nausea and vomiting. So practically my patients, once they go home, they come for the next cycle. So there's nothing in between. It's absolutely safe.
Great. So, Doctor, beyond the treatment itself, what is the advice that you would give to patients and caregivers who are coping with this journey? and not just cope they are not just coping with this journey physically, but it's also emotionally, it's also mentally. So the advice that we'll give to those people more than the patients.
See, one good thing what is there in our country is we have a very close family network.
Yeah.
That's something which is very important in when you treat cancer patients. It's not a one-time treatment. The patient's treatment lasts for 6 months, for some patients 1 year, for some patients till lifelong. So once you have a good family background and good family network, most of the things are taken care of as compared to the Western system. Our system is, I feel, it's quite good. So important part in management of cancer patient is the mental stability and the positive attitude of the patient. It's not only the drugs, but coping up with the side effects. I don't say that there are no side effects, but coping up with whatever side effects, keeping oneself busy, doing light exercises, having a good nutritious food. These small bits and pieces adds up in actually getting a good results. We I think these are the things which I feel are ignored in the management of cancers, but I feel these are very important in the background of what we treat the patient. It's for us, the patient is for 1 day, and then the patient goes home. So it's all about the family members and how they interact. I don't feel that patients invariably, somebody comes and tells us a negative story. One of my relative had and she died in so on. So that's something which we should be kept apart.
Yeah.
It does happen in some patients. I'm not saying that we are able to cure 100% of the patients.
Yeah.
We do have failures as well. And but as the science is evolving, we are getting good results, and we have more cure rates as compared to what it was 2 decades
Right.
back.
So before we wrap up, if a woman listening right now has just been diagnosed with cancer, what is it? What is the one thing that we would want to tell her through you? One thing she's listening to us right now.
I feel the first thing is accept that you have a cancer. That is the first thing, important thing, what should happen. I have seen so many denials. Patient just denies, how can I have a cancer? There's nobody in the family who has a cancer. You know, so we'll take a second opinion, do a repeat biopsy, believe in it that you have a cancer. If your doctor and the clinical picture fits in, your biopsy fits in, believe that it's a cancer. Go ahead with the treatment. Treatment is curable in many cases. What is important is doing a personalized care for each patient. Treatment is different. So get all the workup done, get the staging done. If it's an early breast cancer, it can be cured. You need not get your breast removed. You can have a breast conservation surgery, a good chemotherapy or a targeted therapy which is available. And what is important is once the treatment is over, go back to the society, start working as you were. It's a transient phase. It's a transient phase in life. Don't worry about it. Many of the breast cancers are not going to come back. So don't worry about it. Keep a regular follow up. Follow up is important because in some patients where the disease can come back, which can catch them early, again you have a chance of getting cured again. Yeah. Provided you have a limited stage disease. Yeah. So it's not only the treatment, but also a follow up, having a good, healthy lifestyle further once you are diagnosed with it. So these are the things which are important for the stopping the recurrence of the disease, which can come back. So there are a lot of other things like your diet, your sleeping habits, eating habits, how you work, exercise, nutrition, all those things once your treatment is over and also during the treatment. So, breast cancer is a curable disease. Don't shy away from it, accept it, and get treated scientifically. Right. Thank you so much, doctor. This was a very compassionate and a very empathetic, insightful conversation I feel we had. And thank you so much for everything that you told us. And most of our viewers, I'm sure today they are feeling a lot more enlightened with all the myths also that we cleared for them. Thank you so much for being a part of this conversation. Thank you so much for calling me, giving me this opportunity. And I think breast cancer is on rise, but what is good is it's curable, it's treatable, and the treatment is something which is not too costly for the early stage disease. So please Get yourself screened and get treated.
Yeah, and don't be afraid.
Don't be afraid.
We're here to
Don't be
fight
afraid.
cancer together,
Absolutely.
right?
Thank you so much.
The story of breast cancer treatment is changing. From one size fits all to smarter, kinder, and more helpful care. This has been the Cancer Conversation brought to you by Delarc Pharmaceuticals. Stay informed, stay connected, and above all, stay hopeful.